Hello, sir. Is it audible, sir?
Audible, sir. Yes, sir. You are audible, sir.
Am I audible? Okay. Yeah. We'll start, sir. We'll start, sir.
Yes, sir. Go ahead, sir.
Hello, everyone. Good evening. I'm Dr. Gautam from Apollo, Chennai. Today, we'll see about the approach to dyspnea in emergency. Actually, to be the definition, there is no absolute definition for dyspnea, where the multiple definitions are begin given in the multiple guidelines, where we take it as it's an unpleasant or uncomfortable breathing. In dyspnea, there are certain subtypes, which you can tell as tachypnea, which there is increase in respiratory rate, while the orthopnea and PND, we know like it will be classical of cardiac symptoms, might be lung too, where the hyperapnea is increase in minute ventilation. These are the subtypes of dyspnea. Where the main pathophysiology, you have to know that the pathophysiology of dyspnea is poorly understood. The normal breathing is controlled by
Sir,
the.
please share your slide, sir. Sir, your slide is not visual.
Okay, one second, one second. Now it's visible, sir.
No, sir. No, sir. Your slide is not visual, sir.
क्या आनंद क्या दिक्कत हो रहा है
सर ये स्लाइड शो ये
One
नहीं
second.
शेयर नहीं हो पा रहा है उनसे सर से
हेल्प कर दो
सर वो बता रहे हैं
நம்ம கூட்டாங்க சீக்கிரம் கூட்டிட்டு வாங்க ஸ்லைட் எப்படி உங்களுக்கு ஷேர் பண்றது
सर पुट योर स्लाइड इन यस सर योर स्लाइड इज विजुअल सर नाउ गो
Yeah,
अहेड
yeah. Now it's visible.
ओके यू कैन गो अहेड अरे म्यूट हो गए हैं जी, खोलो। आनंद खुलवाओ।
जी
स्पीकर इज म्यूट। Kindly unmute yourself. आनंद,
सर
क्या दिक्कत हो रही है?
उनसे सर first sir unmute yourself and then sir share your slide. Yes sir, then sir share your.
Yeah, 1 second, sir. Now it's audible, sir.
You are
Yes,
audible sir.
you are visual.
Yeah,
Go
yeah,
go
sure,
ahead.
sure, sir.
Please
Sorry, yeah. The main pathophysiology is there is no absolute definition for dyspnea. The
sir,
pathophysiology of
your
dyspnea
slide is not visual sir. Your slide is not visual. Please open your slide sir.
now, sir.
Sir, your slide is not visual.
Yeah, the causes of dyspnea central.
Put your slide in share slide mode sir. Slide mode.
The causes of dyspnea central abdomen. The central causes would be like post RTA, any injury to the brain, CNS, stroke. Like the pulmonary causes are pneumonia, pneumothorax, any pulmonary edema, or any toxic substance irritating the lung. Abdomen causes are large ascites pushing the diaphragm up, or any severe pancreatitis restricting the movement of the diaphragm. Metabolic DKA or severe metabolic acidosis like in CKD or acute kidney injuries, or any toxic substance or electrolytes imbalance making the patient drowsy and decreasing their respiratory rates. Cardiac, absolutely it is pulmonary edema. Other than that, it is cardiac tamponade or any MI or any pain making them whether tachypneic. Psychogenic, it's absolutely a stress factor, sociologic stress factor. The classification based on acuity of the condition, there are some life-threatening which should be absolutely given the first priority to treat it out. These are airway obstructions, anaphylaxis, epiglottitis, acute severe asthma, the life-threatening asthma, pulmonary embolism, which is causing hemodynamic instability, or any tamponade or tension pneumothorax. The urgent we should give the priorities of spontaneous pneumothorax and Near fatal asthma will be coming into life threatening. The other asthmas will be in the urgent comes. COPD, mild ARDS, Guillain-Barré syndrome, and any pulmonary edema. Non-urgent, which can be treated in the priority C, those are pleural effusion causes a mild tachypnea, any neoplasm with the chronic symptoms, or any pneumonia which a Krebs score of 1 or 2. Initial approach as an emergency, always it is ABCD, airway, breathing, circulation, disability, and exposure are always the priority, whomever it is.
Sir, your slide is not
History,
moving, sir.
now, sir.
Your slide is not moving, sir.
Now, sir.
Now moving, sir.
Yeah. History, we have to check about the history, whether it's an abrupt or gradual, so can differentiate it. Abrupt, most likely it should be any, if it is pulmonary, it should be pneumothorax, or it should be pulmonary embolism, or if it is cardiac, it should be acute tamponade post RTA, or it can be MI or arrhythmia. If it is gradual in onset, it can be TB or any chronic infections or any effusion making them progressively worsening, any neoplasms. Duration, like how long duration, whether it is prolonged like the same as onset, whether the severity of dyspnea, the same as NYHA classifications, it can be prioritized so that if it is 1 and 2 can be prioritized in the OP basis, where 3 and 4 should be prioritized in emergency. Precipitating events, whether the trauma has precipitated him or any exposure to the toxics or any travel history should be prioritized so that we can take the if patient has been traveled to the COVID countries or patient is traveling to the any acute viral pneumonic countries, we have to take priority to it. Associated symptoms, whether the chest pain, whether it can be pleuritic or pleural rub, or it can be central chest pain. So you can check whether it is cardiac or it can be lung. Fever, most probably it can be pneumonia. It can be non-infective too. Pleuritic pain, most probably pulmonary embolism or any pneumonia. Occupational social history, definitely like pigeon Frenches or any farmers, they allow more of lung problems. Physical examination, than history, physical examination will guide you to the certain diagnosis. Ultrasound, CT, X-rays, or the modern technologies might corner you, but physical examination might narrow you without those sophisticated things. So, physical examination and history are two eyes which you have to take care of it, and the absolute diagnosis can be taken with these tools. Global assessment, you have to check for any pulmonary edema signs like elevated JVP, any pedal edema, facial puffiness. So you can come into conclusion of pulmonary edema, whether it can be cardiac or renal. Then you can ask the history about the urine output, whether it is an acute or chronic. Then you can narrow it out. Assess the upper airway and neck. Check whether the airway is patent, whether angioedema or any obstructions or any chokings should be ruled out. Assess the chest wall, the movement, whether they are using accessory muscles or they are using very tachypneic, they are near arrest, whether they are gasping, it should be airway should be taken in the priority thing. Auscultate, check for wheeze, crabs. If it is wheeze, most likely patient should be an airway disease, probably asthma or COPD. Check the history, treat it with an embolization, they will get better. Do the neurological examination. It can be central to whether they might be drowsy secondary to CO2 retentions in COPD or in asthma, but still you have to complete the neurological examination, check their sensorium. DVT, check for DVT, check for calf muscle tenderness, check for leg swellings, check the history. Someone with cancer, someone with cough swelling, you can corner it to pulmonary embolism. Their well score is very high. So that you can go with the investigations, we can corner the investigations accordingly. Investigation, these are the priority investigation which should done first. CT, MRI in the later stages. These things will make sure that we don't lose the patient immediately. You can, in the priority one, someone with saturation of 80, someone is gasping, You don't need to wait for such investigation. Directly intubate, then you can evaluate. If someone is giving you time, someone with the saturation of 92, they are very tachypneic, give them some oxygenation, resuscitate them first, then you can get the history. It's prioritizing. Okay. The investigations are pulse. You had obviously connect the patient to the monitor, check the rhythm, check the saturation, get the ABG, you know whether patient is in type 1 respiratory failure, type 2 respiratory failure, or any acidosis going on. Next, X-ray, whether you can know whether patient has any pneumonia or any lung signs or cardiac, the thing. Ultrasound definitely will check the upcoming slides of priorities of these things. Pulse oximeter, always the first priority because B comes for thing. Essentially, in all patients presenting with dyspnea, determines the degree of hypoxia on oxygen supplementation depends on two wavelengths of light. That is infrared like 660 and 930. It just sends the pulsatile arterial blood and non-pulsatile. Where the AC and DC, the difference between has been ratio and it expressed as a number. That is the saturation. It has its own pros and cons. If patient is in shock or patient is hypothermia, patient is body is very chill secondary to shock or any nail polishes such as black color or any red color or any methylene blue secondary to poisoning, such things might give the false reading. Even carbon monoxide poisoning too. Burns, obviously burns. Okay, in such things you have to relay the arterial blood gas than this. ABG, essential in all patients in respiratory distress, whether you know patient needs ventilatory assistance, someone with asthma, normal CO2, then you have to intubate the patient. A COPD patient drowsy with CO2 of 100, then you can go with NIV. Still you can go with NIV. Okay. Or someone with very tachypneic and their CO2 is 60 and pH of 7.35, still you can go with nebulization. You can wait until the patient gets resolved. You can repeat the ABG. It's about the not the single ABG, it's about the serial measurements of ABG. It should help you out in the thing. X-rays, essential in all patients with respiratory distress of possible cardiorespiratory etiology to support the clinical diagnosis. It also helps to quantify the severity of pathology and it also to exclude certain pathologies. For example, patients with fever who had a recent history travel to China, still they have the new pneumonias are coming out. They are coming with bilateral infiltrates. Day one, you saw the patient who had only the upper lobe minimal infiltrates. You are treating in a OP basis, sent to home. The second day, patient came with severe breathing difficulty who is not maintaining his saturation, who requires oxygen to maintain it out. You did a ABG, who is showing mild ARDS, but you are doing an X-ray, his infiltrates is worsened out. What will you do? That's the thing. So you can prioritize and you can also you can also quantify the severity of pathology. If someone is trauma, severe breathing difficulty, breathes with oxygen, there is no tension pneumothorax, but he is having breathless, desaturates, settles with O2. For that patient, you can do X-ray. But if it is tension pneumothorax, clinical diagnosis. You should not do X-ray to rule out tension pneumothorax. Patient is gasping, who had no movement of chest rise. On percussion, you have hyperresonant directly, fifth intercostal space, put a needle and followed by put a high CD. ECG. If patient is breathless, it can be secondary to severe LV function, secondary to acute coronary syndrome, or any arrhythmia. If AF with hemodynamic instability, which pulmonary edema, then you have to do the cardioversion. Any heart blocks making them cardiac failure, and you can also rule out pulmonary embolisms. Pulmonary embolisms, sinus tachycardia is the more prominent sign which will be eliciting in ECG. The other signs are RBB, whether complete or incomplete, any RV strain patterns, or S1Q3 T3. S1 Q3 T3 is not an 100% sensitivity, just a 20% possibilities in PE. But if it is S1, Q3, T3, you have to rule out PE with the evidence of any suspicions of pulmonary embolisms. Ultrasound. Some people will tell ultrasound will replace stethoscope. Some people will tell ultrasound is the mandatory for all patients. But my opinion, it's dependent on operator opinion. The clinical examination and history cannot be replaced by ultrasound, which will give the add-on information to you. They will tell if someone is barcode, then tension pneumothorax would know it's a clinical diagnosis. Percuss the patient. If it is hyperresonant, obviously it is hyperresonant. Patient is trauma, tension pneumothorax. I don't tell, I will do ultrasound, then I will put ICD. No, put the ICD. You should not waste time by doing ultrasound. It can be few minutes or few seconds. If it is tension pneumothorax, just put the ICD. You're not supposed to wait. Even few seconds, patient might die. You can revive him very absolutely if you intervene him properly. Okay. This is A profile, which the sound wave will pass it directly the pleura. This is the B profile, which denotes patient has pulmonary edema more than 3 B lines. And this denotes patient probably has a pneumonia because this side it is an A profile and this side it is an B profile. This can be secondary to pulmonary edema or ARDS. This is a normal lung. Still it can be a pneumothorax, but if there is an B line, there is no pneumothorax. Pleural effusion, yeah, definitely you can see in ultrasound if it is a massive effusion, then you can tap it out, patient will get better. This is an pericardial effusion. If a patient has a pericardial tamponade post-RT anything, then even drawing a 50 ml of pericardiocentesis will save the patient. Blue protocol, which has been followed universally, check if any patient come with trauma, you have to check for lung sliding sign. If lung sliding sign is present, then fine. If it is A profile, it is an pulmonary edema. So if it is a B line, it is an pulmonary edema, and you can rule out pneumothorax in that patient. If there is an B line, there is no pneumothorax. If it is an A profile, still it can be a pneumothorax, whether it can be thrombosed vein or it can be.
Sir, your slide, your
One second. Now it's seen, sir.
sir, your slide is not visual, sir.
Now, sir.
No, sir.
Now, sir.
Yes, sir. Visual, sir.
Yeah.
Go ahead.
Yeah. If there is no sliding sign, then check for, if there is an A profile, check for lung point. If there is a lung point, there is a pneumothorax. But very minimal pneumothorax can be missed out. For such things, go for CT. NT-proBNP, it is secreted by the cardiac myocytes in response to stretch, used to aid to diagnosis of heart failure, predicted outcomes, and to monitor effects of the therapy. It has higher sensitivity than the specificity and may be more useful for ruling out heart failure than the ruling in. If someone with EF of 30 came with breathing difficulty during the summer times, you did a NT-proBNP, it will be in 30,000s. So like obviously it will be elevated. It doesn't give you much thing. You know patient is in pulmonary edema. X-ray shows you classical pulmonary edema features. You did a ultrasound. Ultrasound shows the classical features of pulmonary edema. So like NT-proBNP has no role to it. Cardiologist, yeah, definitely they can see it out whether it is in decreasing trend or increasing trend, so that they know how to prognosticate the patient. In acute setting, whether you want to diagnose whether the features is lung or heart, then it has a role. If it is negative, someone with ARDS comes with breathing difficulty, EF of 45, IVC collapsing, still I have a doubt whether patient is in pulmonary edema or not. I did a NT-proBNP, it is less than 125 or less than thousands, then I can give him fluids. If it is in 4,000, 5,000, then I have to go for hemodynamic monitoring. If it is in 30,000, definitely patient is in pulmonary edema. Or now the very common term, heart failure with preserved EF. In such things, you can do NT-proBNP, but in acute setting, it has a very big question mark. This is AHA recommendation. In 2024, AHA recommendation clearly tells NT-proBNP more than 25 has been present in most of the young females which have been monitored in the community in Western countries and in American countries. They have a significant positive study to it. So it has a very questionable role. Use it appropriately. AA gradient will help you whether if it is someone with hypoxia, it will tell you, it can narrow the diagnosis. Do ABG, check for AA gradient. If AA gradient is increased, then give oxygen. If O2 is improved, then it is absolutely VQ mismatch. If it is not increased, then it is shunting. Next, if AA gradient is normal and patient have high carbon dioxide, then it is hypoventilation. If CO2 is normal, then it is high altitude, low inspired O2. Now coming to diagnose like disease specifics, asthma, BTS guidelines. If someone with asthma coming with breathing difficulty, evaluate whether it is an acute severe asthma, life-threatening or near-fatal asthma. Give them nebulizations, check whether it improves the patient, do the appropriate needy investigations, do the ABG, check for PCO2. If it is normalizing, then it is an near fatal. Go ahead and intubate. Check for response for the medications. Give them nebulization, back-to-back nebulization. If it is not settled, next steroids. If it is not IV steroids, nebulization steroids, IV steroids. If it is not settling, then if it is patient is keep on gasping or increasing using accessory muscles, wheezes persist, then try to intubate the patient to relieve them if medical treatments are not improving. If patient is in cardiogenic pulmonary edema, AHA clearly tells warm shock, warm dry or wet dry. Treat it appropriately. If patient is in shock, always start them on adrenaline or noradrenaline and dobutamine. If patient has adequate BP, then start them on furosemide infusions along with nitroglycerin infusions. Check for hypotension with NIV. The positive intrathoracic pressure will relieve the pulmonary edema and also their symptoms. Patient will get better. Investigations, do the echo in emergency, check for LV, check for IVC, check for B lines, do a X-ray, check for features of pulmonary edema, then you do what to be done next. If someone with pneumonia comes with breathing difficulty, whether you have to admit the patient or discharge the patient, that will be the major confusions. Major pneumonia in India are viral or secondary to scrub typhus or bacteria. Okay, so like still I can appreciate many doctors will say it's a viral pneumonia and treat with antibiotic. No, you can wait. But still, whether it is viral or bacterial or enteric, whatever it is, you have to see the curve 65. If curve 65 is 0 to 1, you can treat them on OP basis. If it is 2, admission or close OP management, or 3 to 5, definitely patient needs admission. Whether in HDU or ICU, it can be decided as per patient thing. This is summary. Someone with breathing difficulty, check whether the patient has airway compromise. If yes, maintain the airway, supplement the oxygen, connect the monitor, check for SpO2, check for any arrhythmia, check the BP. If everything's stable, Let's go for the next step. That is like any acute ventilatory compromise, then again go for ABC. If any unequal breath sounds, then it is tension pneumothorax. Do the percussion, check for any hyperresonant, dull, anything. If it is hyperresonant post-trauma, go for ICD. No, next go for other investigations. X-ray, ECG, ABG, and you can go it accordingly. If someone on V's, hyperexpansion, clear chest X-ray, type 1 respiratory failure, then you can go with asthma or anaphylaxis. History will tell you. Check the history. Patient will classically tell chronic asthma comes with breathing difficulty during the winter season. Anaphylaxis, patient would have ate any fish or prawn who had previously who are allergic to it, or any sting bites. This will give the diagnosis. Or someone wheeze, hyperexpansion, clear X-ray, type 2 respiratory failure, consider COPD. Patient have wheeze, silent chest, whatever it is. Bilateral crepitations, interstitial fluid on X-ray, type 1 respiratory failure, who has cardiac symptoms, severe LV on echo, consider pulmonary edema. Focal signs on X-ray, type 1 respiratory failure, patient has febrile episodes or recent travel or family history, recent exposure of recent pneumonia in the family history, consider pneumonia. Focal clinical signs, this is diagnosing chest X-ray, type 1 respiratory failure, hyperresonant, consider trauma. It's like patient, someone with trauma, consider pneumothorax or pneumothorax. Clear chest, normal X-ray, but have abnormal ECG, not only S1Q333, but also sinus tachycardia, RBB or RV straight pattern, that is T wave inversion in V1 to V4, abnormal AA gradient, consider PE. Clear chest, normal chest X-ray, reduced carbon dioxide, metabolic acidosis, who has comes with decreased urine output, who is known CKD, who used to dialysis weekly thrice, comes with severe breathing difficulty, who missed his dialysis, couple of dialysis in the past, comes with, then consider it's a renal failure. Treat them appropriately. ABC first. You can't come to it. You can't compromise on it. Someone with breathing difficulty, someone has protected airway, next for B. Whether they are using accessory muscles, whether they are wheezing, settles with nebulization, no. Not settling, go for NIV. Or cardiac patient, someone is using accessory muscles, directly go for NIV. Increased thoracic pressure will decrease their load, decrease their competence, and it will increase their life expectancy. If you not put them on positive pressure ventilation, it might lead to the catastrophic events. It depends upon patient to patient. The conclusion, oxygen is treatment of hypoxemia, not for breathlessness. Someone with saturation of 100, they are breathing difficulty. I have seen many doctors keeps oxygen. No. If someone is hypoxia, address the problem, treat the problem, not to keep oxygen. The respiratory drive will compromise. Oxygen should be prescribed to achieve a target saturation of 94 to 98 unless they are not COPD or any chronic type 2 respiratory failure. If they are chronic type 2 respiratory failure, then target is 88 to 92. Proper history and examination will make patient comfortable and appropriate diagnosis. These are my references, mostly from NICE guidelines, BTS guidelines, and AHA for the cardiac things. Thank you. Any questions, please? Excuse, sir?
Sir, some questions chat box, sir.
Yeah. Novel biomarkers to predict the severity of dyspnea. It is a disease specific. As I told, if NT-proBNP for cardiac failures, there is still the study going on for PCTQ in pneumonia. It has definitely no role as of now. And the disease specific. You can't grossly tell any specific biomarkers for dyspnea. It's a disease specific. If you ask any disease specific, then we can corner it out. It's not generally there is no general biomarkers for dyspnea. Role of bicarbonate in severe metabolic acidosis secondary to sepsis. Yeah, give sodium bicarbonate. Yeah, see, you have to understand one thing. There is a study called ICU bicarb study. It's called ICU bicarb study, which clearly tells the bicarb is indicated only in two indications. One is someone with acidosis and pH less than 7.2 and bicarb is less than 20. It's not vice versa. It is pH less than 7.2 and bicarb less than 20. Then bicarb has a role. It doesn't have any benefit on mortality, but you can avoid renal replacement therapy in such patients. Might be prolonged or avoid, but it absolutely no benefit on mortality. Similar scenario in DKA, we are correcting dehydration, sir. Meanwhile, any role for bicarbonate? See, patient is trying to compensate. Patient, our body, as it's trying to compensate the whole physiology, you should not prevent it. If someone is tachypneic and their respiratory rate is increased, they're trying to wash out CO2 to compensate the thing. I have seen in ER, someone with comes with severe dyspnea and the sugars will be 500, classical DKA or on whatever it is. If you're going to intubate the patient will die immediately post intubation because his body is trying to compensate it, which you prevent it out. You intubate the patient, CO2 build up, acidosis worsen, cells die, patient will get arrest. So I'm not telling not to intubate such patient. Intubate in an appropriate manner. Hyperventilate such patients. Because of hyperventilation, CO2 just wash out. Because of washing out CO2, pH still try to compensate. In DKA, bicarb is indicated only if pH is less than, some studies tells it is less than 7 and some cells 6.9. We followed 7. Hydration will help patients to overcome the acidosis, not the bicarb. Hydrate the patient, start them on insulin, try to correct the insulin sugars levels between 75 per hour. Hydrate the patient, monitor the urine output, it's sufficient. Medication for acute exacerbation of COPD. BTS guidelines. British Thoracic Society clearly tells same as asthma. Nebulization, if short-acting beta agonist or ipratropium bromide, next long-acting beta agonist. If not settling, then go for theophylline infusion, repeated magnesium sulfate infusions. If not settling, before that, put the patient on NIV or BiPAP, whatever it is. It will help the patient to get rest to their respiratory muscles, wash out the CO2. You try to compensate it. It relieves the patient's symptoms in the thing. Mostly COPD will get exacerbate secondary to infection. Address the infection, whether it can be viral or bacterial. Treat the pneumonia or treat the infection or treat the thing whichever exacerbates, patient will get better. The same protocol, which anything. If patient having compensatory respiratory alkalosis and pH is normal, we have not given bicarbonate and pH is above 7.2 despite respiratory rate as being 50-60. See, that's what I have told. It is 7.2 and also the bicarb. If patient is tachypneic, check what is the reason for his tachypnea. If it is DKA, I won't give bicarb, not me. There is no guidelines to tell to give patient a bicarb. Give them fluids and correct the, if patient is in DKA, correct the acidosis by giving them fluid and normalize their anion gap, normalize the sugar level, patient will get better. Bicarb, it will increase the CO2. It's not, it's always a double-edged sword. If you give bicarb, patient will increase in production of CO2. They have to use extra energy to wash out those CO2s. So it's always a clinical call. Magnesium sulfate dose and route of administration, bolus or infusion, when to repeat. Yeah, it is 2 gram. It can be given as infusion over 30 minutes. If it is not settled, you can repeat it in a similar. You can again put on a continuous infusion like 4 grams over 12 hours. You can repeat it another 4 grams over the next 12 hours. Magnesium sulfate. Ventilator settings for CO2 retention, stepwise how to proceed. Yeah. See, you have to address whether the patient is an asthma or COPD or secondary to cardiac functions. Whatever it is, I will choose a tidal volume of 6 ml per kg. Always respiratory rate should be decreased because you need IE ratio, I inspiratory ratio should be a shorter time and expiratory ratio should be the longer time. So if rate is between 10 to 14, you'll have more time for expiration. Patient will have washout CO2. So more, the lesser the rate, more the CO2 will get washed out. PEEP, it depends. Ideally low PEEP for both COPD and asthma. You can measure the intrinsic PEEP and 80% of the PEEP can be addressed to the patient. Intrinsic PEEP can be measured by holding the expiratory hold for 3 seconds. NIV settings for type 2 respiratory failure. Yeah. See, always start with the IPAP, EPAP of or pressure support PEEP of 10-5. Increase the PEEP slowly as patient is tolerating it. If there is CO2 retention, there should be a more gap between IPAP and EPAP. That is pressure support and PEEP. There should be more gap. The more the gap, the more the thing, patient will wash out CO2. You can analyze the patient tolerance and you can appropriate setting can be put accordingly. Can oral Kudel's airway prevent aspiration, sir? Yeah. See, if patient is aspirating, first you have to address whether it is a reversible or non-reversible cause. If someone with hypoglycemia, someone with seizure is aspirating, then you can wait. Put the patient on left lateral position and you can wait. Or patient is chronically aspirating, someone with myasthenia gravis not settled with treatment, or someone with stroke who doesn't have their gag reflex, who have like major stroke on their dominant side, patient is aspirating, then directly intubate. Definitive airway is a definitive measure. If someone is having some hypoglycemia or any reversible measures, then you can wait until that, put the patient on left lateral position, prevent the airway, then you can avoid it out. Not every patient with aspiration requires intubation. Antibiotic in patient with reversible aspirations or any role for Metrogyl. Yeah. See, you have to differentiate it. All aspiration doesn't require antibiotic. You have to know the difference between pneumonitis and pneumonia. If patient is aspirated, patient will have pneumonitis, not pneumonia. Empirical antibiotic has no role for pneumonitis. If patient is having pneumonia, you can assess. If patient is developing fever, increasing in total count, increasing in oxygenation, increasing requirement of ventilators at this peak, then you can add antibiotic. Not all aspirations require antibiotic. Hydrocort in pneumonia, sir. See, post-COVID era, it gives us a very absolute data on steroids on pneumonia. If it is severe ARDS, definitely it has role even in acute settings. Otherwise, it has no role to it. There are multiple studies to enlighten it.
Okay, sir. Thank you very much, sir.
Yeah, sir. Thank you, sir. I thank everyone for their patience. I hope it's little bit clear on dyspnea. You can handle it out. Thank you for the opportunity. Thank you for the Indian College of Physicians for the absolute opportunity. Thank you, sir. Have a
Thank you,
good
sir.
day. Good night.